Thank you all very much for inviting me. I kind of thought hard about how to present this because thinking about the role of allergy in EoE is quite a big subject. So I've picked snippets, and I'm afraid I've had to talk about some immunology because if I don't, then if you don't understand the terminology that I'm talking about, then it won't make sense. This might be teaching my grandmother to suck eggs, but I hope that making it clear will make it easy for everybody to know exactly what we're all talking about with the same terminology. So what I thought I'd cover with you today is that I'll go through what allergy is and what does non-IgE and IgE mean, and talk about when people use intolerance and allergy, because people seem to use it fairly interchangeably in the gastrointestinal literature, and they kind of mean different things. And then I'm going to talk about the allergic march, because that gets talked a lot about in allergy, and EoE to date hasn't really been included in those discussions, but maybe it ought to be. And then I'm going to talk a bit about atopic history and why history taking of allergy is important. Again, it depends which service you present to, and that is often dictated to by age. And I'm a paediatric allergist, which may be very different if you've presented to adult services where you often don't see an allergist, but it's way more common if you're a child. And then I'm going to talk about testing, which is why I do need to talk a little bit about immunology to understand why allergy tests might be done, but why they're not always very helpful in helping you manage EoE, but are incredibly helpful for other associated conditions that often come with that eosinophilic esophagitis, and why at the moment we still need to do biopsies for the diagnosis. And then I'm going to talk about immediate allergies and some of the side effects that can potentially be associated with desensitization. So it's a little bit of snapshots of things that I often get asked, and I hope that that's helpful. So first of all, a bit of terminology. So lots of us have adverse reactions to foods. So if you eat a food that's got salmonella in it, you will vomit, because that's called food poisoning, and that's toxic. So when we're talking about food intolerances or allergies, we're not talking about those adverse reactions. We're talking about non-toxic ones. And then how do we determine what's a food intolerance versus a food allergy? Well, it comes down to, is there likely to be an immune, as in something in your immune system that's the mechanism that underlies it, or not? So if there's an immune mechanism, then you can call it an allergy. But if there isn't, and it's due to a chemical reaction or a property of the food, then it's a food intolerance. So a good example of that would be that if I drink caffeine, a nice load of coffee, I will get a fast heart rate, I'll sweat, I might feel a bit dizzy if I had a load of it, and I might get diarrhea. That's not a food allergy. That's because caffeine has certain pharmacological effects on my body. It's got nothing to do with my immune system, it's just how I react to it. And some people will be more sensitive than that, okay? So I'm very clear that when I'm talking about allergy, I am not talking about any of those effects that some people may be more sensitive to than others. And then when I talk about food allergy, I talk about IgE mediated disease and non-IgE mediated disease. And what do I mean by that? That's where I get into my immunology. So allergic inflammation simplified. So basically we have an allergen that gets picked up by something called a presenting cell, because we're very polite in allergy and things need to be introduced to our immune system. And the antigen presenting cell is the person who introduces any bit of protein, which is your allergen, to the immune system, and it presents it to this TH cell, the T cell. And in allergy, it's the TH2 cell that's involved. And it can respond in multiple ways, but the three big cells that are involved in allergy are eosinophils, mast cells, and B cells. Okay, and essentially it's B cells which produce IgE, which create IgE mediated reactions, and mast cells are involved in that. And then the eosinophil side, along with T cells, are involved in the non-IgE mediated disease. So if you think about the IgE mediated disease, which is the immediate type allergy, the first time you meet an allergen, I've picked a flower here, it doesn't really matter what you pick, it meets the T cells present it to your B cells, you make a load of antibodies, and those antibodies go and sit themselves onto the outside of a mast cell. And they sit there with their arms out, waiting to meet the allergen the next time it comes to your body. So you don't make a response the first time you meet it. However, the next time you meet that allergen, it comes in and it binds, because it's specially made to fix those antibodies, and it sits on those receptors, and it makes those mast cells open up and release everything they've got inside them. And everything they've got inside of them is things like histamine and other cytokines that make you wheeze and develop hives and sneeze, everything you associate with an allergic reaction. And if it carries on happening, then you get more wheezing, and then it recruits more of those non-IgE mediated cells, which is your eosinophils and T cells. So you can see both of them get involved. But when we talk about IgE mediated reactions, that's what we talk about. It's the immediate stuff, and that's what we measure, us allergists, in tests. Okay, so we're almost done with the immunology. IgE mediated, non-IgE mediated. Have a test, don't have a test, essentially, if you're an allergist. And what happens in allergy, because the bit of the Th2 response is there for a purpose, it's a part of our normal immune response. We didn't just have this bit of the immune system that doesn't have a function. It has a function, and it's supposed to be there to ward us off from parasites and all those nasty worms that we used to be exposed to all the time. And it's supposed to be kept in checks and balance. Allergies, when it goes wrong, because it's reacting to things that it shouldn't be reacting to. And sometimes that's because it gets exposed to things because our body doesn't protect us. So for example, when your skin is damaged, then allergens can get in and get presented with that lovely antigen presenting cell, and then you can mount an immune response. But normally our gut is really clever, and our gut is actually the bit that usually protects us and produces tolerance, and actually has regulatory cells that switch it all off. So our gut usually protects us. But actually, when we get allergic gut disease, it goes wrong a little bit like the skin, and this all gets broken up. So our gut is an amazing immune organ. It's the biggest single sensitizing organ in the body, and it has all these single layers of epithelium with the allergic cells sitting underneath it. And that's why we can't get to it very well, because unlike the skin where we can see it, the gut's inside and the inflammation is going on here. So we can't see it, and we can't get to it without biopsying it. Okay. So now you can already see why we're struggling. So you eat your food. If you've got immediate food allergy, you produce those IgE antibodies that I can test for. But actually, if you've got eosinophilic esophagitis, you get a breach in that barrier, and then you go down that non-IgE mediated response where your eosinophils are busy, and it's in the mucosal layers of your esophagus. So the tests aren't going to work, and that's why you're needing to biopsy, because we haven't got any biomarkers that are reliably used yet. I hope I'm making sense. And your gut's really important. So it's the biggest mucosal surface area in the body by far, like 10 times as far. It separates us from a sterile internal environment from all that stuff we swallow. It processes food for growth. It prevents harmful bacteria and viruses getting in. It has mucus that traps all the gungy particles, and it destroys loads of pathogens and denatures to allow bile acids and change the pH. And only 2% of allergens get absorbed through the tract. So it's really dead clever, and it's amazing it doesn't go wrong even more often than it does. So impressed with the gut, it's so clever. So what about eosinophilic esophagitis? So this is data from the US showing that it actually peaks EoE in sort of the mid-adult years, but actually you can see it's represented throughout childhood as well. And actually we know that recognition of it is going up. The prevalence is increasing. This is a new disease described first in the 70s, and it's increasing. So it's something that we're still very much learning about. And what's the association between atopy? Well, we know it is associated with other allergic conditions. A pretty good study in 2017 showed that looking at both adults and children, that 63% of all the patients diagnosed with EoE in this birth cohort study had one or more comorbid allergic conditions, 44% of whom had asthma, only 27% have had allergic rhinitis. I do wonder how hard they looked. 25% having atopic dermatitis, and 16.9% IgE mediated disease. And that's way more common than the general population if you look across adult and pediatric data. And if you think about it, that stuff I was showing you on mechanisms, the mechanisms are common for mixed and non-IgE mediated disease. And then further studies have looked at sort of hazard ratios of having a primary diagnosis of one of these conditions and then having a second condition. And you can see if you have atopic dermatitis, you've got 2.5% hazard ratio or odds ratio that you'll have food allergy, 1.5 asthma, 3.2 EoE, and so on. And actually the biggest risk factor is if you've got IgE mediated food allergy, you've got a 9.1% odds ratio of having EoE. So that's really big. What's interesting is that those studies weren't showing particularly high risks for allergic rhinitis, which doesn't fit with what you just polled. Now, that is partly because allergic rhinitis is more common in the general population anyway, and secondly, because allergic rhinitis is not well diagnosed medically. So I think there are some confounding variables to be had. And this is an abstract. It hasn't actually been published, but it was an abstract that was presented at EAACI in 2019, which is pediatric data, which interestingly did show that the commonest comorbidity was allergic rhinitis. So that concords more with what you're telling me. So that was interesting. So the allergic march, what is the allergic march? So the allergic march was actually birth cohort data, which looked at prevalence of allergic diseases over time. It was then taken to mean causative stuff, so that if you had food allergy and eczema early in life, then that was going to cause you to have asthma and then develop rhinitis, which I have to say is not what the data or the allergic march is about. All the allergic march tells you is the population risk of having allergic conditions at any age. Now, clearly, there are children who do follow the path, the classical allergic march, who get eczema in the first 3 months of life, who then develop immediate food allergy, who then develop asthma and then develop allergic rhinitis. There are equally children who do it completely out of order and don't follow that pattern. And there are children who develop asthma and rhinitis who never develop food allergy. The risk, if you have eczema in the first year of life that is moderate to severe, is that you have about a 50% risk that you'll develop a food allergy. And equally, if you have food allergy in the first year of life, there's about a 50% risk that you'll develop asthma. But equally, you can have asthma without having any of the others. And the actual number of children who fit the phenotype of the allergic march is actually only 3%. So actually complex multi-system allergic disease following that allergic march is actually only about 3%. And that's likely to be because actually what's involved in that is lots of things. So it's going to be genetics and it's going to be environment, all interacting, and it's going to be multiple environmental factors interacting, producing that. So should we be thinking about EoE in this? Because actually, we know that allergies are more common in children and adults who have EoE, and the mechanisms that sit behind the immune regulation are more common. And it was proposed in 2018 by Hill that actually maybe we should start to think about EoE as part of the atopic spectrum. And if you were to do that, that's actually much more what it would look like. And you can see the difference in his data around allergic rhinitis, which I find fascinating, that they have such a low prevalence of allergic rhinitis, which is way lower than other studies. And I can't explain that. And I would need to go back through in detail how they looked at that, because it is a much lower kind of incidence than one would expect. But one can argue that actually we should be thinking about EoE as potentially part of that allergic march, but thinking that this is not directly applicable to most individual children. And I really want to make that quite plain, because it doesn't account for most children. So thinking about how people present with EoE and history, so thinking about that allergic history. So adults tend to present slightly more obviously than my younger patients. So they tend to present with reflux symptoms that are refractory to management, with food impaction and problems swallowing. Whereas children seem to make my life really complicated and present with aversion and vomiting and reflux symptoms. And it isn't till they get older that they tend to present with more classical symptoms. And that's shown very much by this, that they'll present with vomiting and abdominal pain and feeding disorders, and they don't move into the adult pattern until they get a bit older. And generally food allergies in children can be immediate, intermediate or delayed, and they can be part of a systemic or localized response, and they're often associated with motility problems and pain. And that runs from a total IgE mediated type picture to a mixed picture, and then a true non-IgG mediated picture. And non-IgE mediated food allergy in pediatric practice includes the enterocolitis and enteropathies, and then a group of eosinophilic disorders, of which eosinophilic esophagitis is by far the commonest, and then some associated conditions, of which some do seem to respond to diet. And we tend to see the enteropathies and enterocolitis early, and then functional symptoms and eosinophilic esophagitis throughout the range. But the difficulty we have is that the symptoms that younger children present with overlap symptoms of just about every other gastrointestinal disease children can ever present with. And they're very non-specific in a condition where allergy tests are extremely unhelpful. And you would think that children with suspected EoE will present to a gastroenterologist, and that children with allergy will present to an allergist, and children with mixed conditions will present to either one or other of us or both. But in reality, they don't. And actually, children and adults present to GPs, pediatricians, and to accident emergency. And actually, it's not a common condition. And one of the biggest problems is getting pattern recognition of younger children and considering the diagnosis in adults to be there. Because if you don't think about it, you don't think about the other allergic things in the history, you won't even consider EoE as a possible diagnosis. So you need to think about the other allergic comorbidities. And whenever I see someone, I start at the beginning, even in my teenagers, because most of them have problems from the beginning. And actually, I think often, even in my adolescence, there will often have been an early history that has probably been missed. And you need to go from top to bottom, as well as looking at the nose, the chest, and the skin. So why do we need biopsies? Why can't I just do my allergy tests? Well, it's, as we were talking about, where is the inflammation? The inflammation is sitting under the epithelium in that mucosal layer. And my allergy test, because they measure IgE and it's not IgE there, isn't going to help. And finally, symptoms don't really correlate very well with what we see on histology. And unfortunately, there's a large gap in our knowledge of what happens, but we do know that the longer you have inflammation, the higher the risk of developing fibrostenotic disease, but we don't know in whom. And that makes life very unpredictable for both patients and for doctors who are looking after you. So that's why people continue to biopsy. So I think I have explained why my lovely IgE tests don't work, because it's not an IgE mediated disease. Atopy patch tests were tried, but it's as good as flipping a coin. So you can flip a coin. Dietary elimination clearly can work, but symptoms might improve, but you still don't know what's going on at the cellular level, and symptoms don't correspond. So unfortunately, you do need your biopsies. So what allergy tests are out there? So there are lots of companies that are advertising tests of various varieties in complementary testing and what looks as quite respectable tests. But the allergy tests we use that have evidence behind them are essentially IgE tests, which are for immediate allergy. There is atopy patch testing, which is for contact dermatitis, and they are validated for that. And then challenge testing and provocation testing, which are again for immediate type allergies, which this doesn't work for. So why would I use allergy testing in EoE? I've just done myself out of a job quite convincingly. Well, clearly to identify coexistent comorbidity. So if there's IgE mediated disease, if I was considering immunotherapy for one of the comorbidities, and prior to introducing a food for which there is possible IgE mediated disease. So how do I use my allergy tests? Well, again, they're not the world's greatest tests. I'm really not doing myself a favor here, am I? So the allergy tests that you'll commonly see are the blood tests, the specific IgEs, and the skin prick tests. But a single level doesn't tell you an answer. So, I mean, what you'll see when you go is something like that, a skin prick test or a blood test. So in children, we do know upper limits of skin prick tests, which in high risk children with a history of reaction pretty much give you a clue that they will fail a challenge. However, if you've never been exposed to a food, that is not entirely true. So there are children who haven't been exposed who can pass. And the same with the blood tests, that we have levels of challenge in a high risk cohort presenting to a tertiary allergy unit at which 90% of children will fail a challenge. Just look how different those numbers are. So for cow's milk, the level is 32, and then for egg, it's 6. They're wildly different. And some labs, sadly, still report classes of 1, 2, 3, 4. And as you can see, a class of 32 and a class of 6 would kind of fall in these ranges. So they're really unhelpful and should not be used. But the point I really want to make about the testing is that actually the probabilities, they're probability tests. So if you think about a child who has never eaten peanuts, never reacted, the population level of peanut allergy is about 2.5–3%. So if they had a test with a low result, then their risk after doing a test would take them to a risk of 1%. If they had a medium test, they'd have about 10%. And if they had a tie test, they'd have 99% risk, okay? So actually, not a high risk. So you'd probably introduce peanut on both of these tests, okay? Now, if I took a child who'd reacted to peanut, we know that about 50% of children will pass challenges, even with a clear history of reaction. So if I give exactly the same results, so this child who has had a history of reaction with that first test result now has only a 2% chance of failing. So actually, he's quite likely to pass a challenge. I'd challenge him. And if he had that second test result, the other one had a 10% chance of being allergic. He has an 80% chance of being allergic. And if he had the high test, well, it's so high, he's certainly allergic. So you can see the same test results in a different patient with a different history produce a completely different result and how I would act. So allergy tests aren't, this result means this. You have to look at the history of what's happened. So you can't use them just as a normal test, which makes life a little bit difficult. So what's the role of allergy tests and diet? Well, we know that dietary manipulation is pretty effective. The evidence is better in children, and I think that's something to do with compliance, but because parents make children stick to diets often far better than adults will, even though the diets can be quite horrible. But skin prick testing does not help. So essentially, if you do a 6-food elimination diet, you can get people into remission 74% of the time. But in pediatric patients, often, if you just take out one food, you can put patients into remission. And the most common food in children is milk. So if you just take out milk, you'll often get 65% of children to go into remission. And we know that the foods that are involved are milk and wheat and egg and soya. And if you look at taking those foods out, you'll get most children into remission. Now, clearly, that's a pretty unpleasant diet. And often we will just take out milk and wheat, milk and gluten. And that is kind of no worse than doing a load of tests and trying to take it out. Now, clearly, if you take out and do an elemental diet, you'll put 95% of patients into remission, which is actually better than giving topical swallowed steroids. Great, but actually the side effects of doing that socially is horrendous. But actually you get really good remission on often a 2-food elimination diet. But clearly it often isn't acceptable as people grow up and they don't want to continue it. And there is no long-term evidence on long-term exclusion of it. And we know that if you take the exclusion out, that people relapse. So sadly, the testing helps with lots of other things, but it doesn't help diagnostically, and you still need to biopsy. What other tests are out there? I'm going to run through these very quickly. Well, applied kinesiology. Essentially, you hold your arm out and you press, and then the person holds a food and then you press again. I think I can convince you it's not helpful. Vega testing, really popular, and it looks technical, but this isn't a voltmeter, and you put the food in here and you hold it. Absolutely no evidence. Basal auricular tests and hair analysis, no evidence. Nampurid test, which involves a bit of Vega testing, acupuncture and muscle testing all combined, no evidence. And I do a very nice lecture where I actually demonstrate all of these, but it really needs to be done face to face. And IgG testing, so there are lots of companies out there looking at this, and they will offer 90 to 100 food panels on there. It is controversial and unproven, and to date, whilst it is being investigated, and I will say that IgG is being looked at, and IgG4, at present, I would say there is no evidence to support what the companies are claiming. So IgG and the various subclasses are part of a normal response to exposure, okay? And in fact, in many responses, when you look at when you give allergen immunotherapy, when you're first exposed to an allergen, you'll see rises in IgG4 as part of a normal response, and it may actually be associated with tolerance. So I think at the moment, I would say that IgG testing is not validated. And then finally, onto immediate allergies and desensitization. So I'm sure you're aware that pollen desensitization has been around for over 100 years, but obviously we are looking now at introduction of food as a method of treatment of immediate food allergy. And giving a food, could it be provoking eosinophilic esophagitis? There's lots of case reports out there suggesting that it does. The rates varying from about 2 to 5% for both aeroallergens and for food. SLIT is currently contraindicated, so that's sublingual or oral immunotherapy for pollen is contraindicated because of that risk for pollen immunotherapy. For food, you certainly should be screening for EoE before you embark on it. And if you develop new sensitization, then unless there is a really compelling reason to want to continue, most people would discontinue. And the evidence to date is that most EoE remits on discontinuation. And this was a review article for milk, peanut, and egg for desensitization and rates of eosinophilic esophagitis. And you can see the rates are varying between foods, somewhere between 2% and up to 6% of eosinophilic esophagitis. So that's my whirlwind tour of is allergy associated, which I think you could summarize as a big yes. And the allergy tests are generally not helpful for EoE itself, but actually very helpful for all the other comorbidities that are incredibly common. That's my usual joke slide that I just love to put up. And any questions, please, at the end. And I hope I didn't really annihilate you with immunology.
Not at all, Sharon. That was a fantastic presentation, and I truly appreciate that we gave you quite a challenge trying to cover that all in one evening.